right. Whilst people are still coming in, I think I'm going to start with the introduction. So welcome back to this last session of iCAAD 2019. It's quite moving. My name is Christoph Sauerwein. I am the Academy Director of iCAAD, and it's my pleasure for the second time of the day to welcome Dr. Stefanie Carnes today at iCAAD. And it's a very important presentation to my heart, because I really insisted for Stefanie to come, and I know it was difficult with your schedule over the last weekend. So let me just introduce again Dr. Stefanie Carnes. Dr. Carnes is the president of the International Institute of Trauma and Addiction Professionals, ITA. She's also senior fellow for the Meadows Behavioral Healthcare, and in that respect, she's also the clinical architect for Willow House at the Meadows, relationship healing for women struggling with sex, love, and intimacy disorders. So in that respect, you're not only a researcher, an academic, but you're also a practitioner, and you never forget to help people, even though we like research. I think that's you summarized. I gave the long version earlier today. You're an international speaker. You're also the author of several books, the last one being Mending a Shattered Heart, a guide for partners of sex addicts. We tend to forget the partners, the forgotten ones. It's a beautiful book. Now, let's get into what brings us together right now. Complex trauma in women with compulsive and addictive sexual behavior. I said I insisted for that presentation to happen. I'm a clinician. I work with sex addicts a lot. I work with attachment. I work with relational and childhood trauma, and I observed that very little was done for the most abused majority in the world, women. 50.8% of the human races are women, and they're abused all the time. And I was adamant that we give a voice to that major issue. And I turned back onto Stefanie because I knew she was the expert to speak about it. So it's a personal conviction that we're in the right place here now to address a major scandal. We've recycled male treatment modalities for women. It's time to look after women and their pain and what happened, and to stop all that. So that's my personal moment here. Thank you for listening to that. And with that, Stefanie, a warm welcome. Thank you. I forgot the most important thing. At 5 p.m. in this hotel, they have an alarm fire drill of 2 seconds. So for 2 seconds, we'll have a siren going on. I don't know what it means symbolically, but please don't do anything. There's nothing to be done. It lasts really 2 seconds. It's a burp test. Okay, so don't be surprised. No trauma. Hope. Thank you.
Well, thank you everybody for coming. I know it's the last session of the day, so you guys must be the truly dedicated still here at the end of the day. So thanks for coming. Just so I can get a show of hands, how many of you were not at my earlier session? Okay, a lot of you. Okay. So earlier we talked about the controversy around sex addiction, how difficult it's been to get it into the DSM, some of the criticisms of having that diagnosis, and some of the concerns that diagnostic category brings with it. Things like concerns about getting like sex offenders off the hook in court cases, over pathologizing sexuality, pathologizing sexual minorities, those types of things. And then we also talked about how it is a real condition, and I shared with you many of my patient examples. And so that gives you kind of shares with y'all what I talked about earlier to give you a little bit of a background. Now, we're going to focus this afternoon on women specifically. And it's been, from my earlier presentation, you heard, just how difficult it's been to legitimize sex addiction. And most people think about it as a male disorder. And it's even more so, I think, even more stigmatized when we talk about this issue for women. Yet this is a big issue for women. It's much more common than people think. And so I'm excited to be able to kind of shine a light on that this afternoon, and to also be looking at what happens when we have complex trauma involved, and that obviously complicates treatment. So, all right, so our agenda, here's my full disclosure. Christophe told you where I work earlier. So our agenda for today is to talk about sex and love addiction in women. I'm going to share a case example with a little video snippet of one of my clients talking. We're actually on the phone. I'll explain that when we get there at the time. Then we're going to talk about complex trauma in female sex and love addicts, and then we'll talk about treatment issues. So one of the things when we're talking about sex addiction in women is most women will not come in to treatment seeking treatment for sex addiction. We see that a lot with men. As I mentioned in my earlier talk, no matter what the problem is, they'll all call themselves sex addicts. With women, we have almost an opposite problem. They oftentimes don't identify as sex addicts. So they'll, and oftentimes for example, in our treatment center, we don't use the term sex addiction as the primary title of our treatment program. We talk about intimacy disorders, because women oftentimes don't identify readily with being sex addicts, don't relate to that. And you'll hear them use all sorts of terminology. Some of them will identify with sex addiction, but you also hear love addiction a lot, relationship addiction, porn addiction. Some people will identify with the idea of traumatic bonding, and we'll talk about that as we go along earlier today. Some of them will come in with sexual aversion. We have high rates of sexual trauma. So in our program, we have everything from prostituted women to trafficked women to sexual trauma survivors. We usually have a lot of rape victims, lots of infidelity, lots of porn addiction. So we have a real mix of presentations. And so we look at it oftentimes as an intimacy disorder. A lot of women will identify with that as a label, so to speak. Attachment and complex trauma. So we tend to be a little bit more flexible with names when we look at women with sex addiction, sex and love, intimacy disorders. As I mentioned earlier, it's not just a man's problem. So we're starting to see much higher rates of women. There was recently a study that was done on a nationally representative sample in the U.S. of how many people struggled with out-of-control sexual behavior, and they found 10% of men and 7% of women, which was much higher than they originally anticipated. And one of the things that we're seeing in terms of trends is, for example, with pornography, much higher use of pornography for women. So, for example, they talked about 2017 as being the year for porn for women, because rates went from 13% to 26% of porn users are female. So they all, pretty much doubled in 2017. So, in porn for women in 2017 was one of the top search terms. So women are starting to look at porn at much higher rates, using sex apps and apps with geolocation features. That type of thing is very, very common. So I'm going to start off today with sharing a case example with you all of one of our clients that recently came in for treatment. And it's a very touching case because she almost died. And so what happened was on Friday, she had a plan to kill herself on a Friday, and she had everything set up. She was going to take herself out. She had the plan. It was all set up. And she met with her therapist that week, who gave her some testing. He did if any of you knows it, the SDI, which is a very comprehensive profile of your sexual behaviors. And he got the results and was so surprised at how extensive and acute her sexual acting out was. He called her on Friday morning and said, I need to set up an appointment to see you. I normally don't see people on Saturday, but can I see you on Saturday? And she said, well, I can wait one more day before I kill myself. And so she said, I'll just do it tomorrow night. And so he invited her in, and basically he said, "You don't have to live like this," and sent her to treatment. And she went, and so it was, very, very positive. But she's a very classic example of what I would call more of a contemporary sex addict. This morning we talked about the difference between contemporary and classic sex addiction, and our contemporary sex addicts are people that get on with very early exposure to pornography when they're young, lots of graphic, intense porn, lots of access to apps and digital technologies. They tend to have less trauma history and less attachment wounding, although this particular patient has a lot of trauma history. Okay, so here's a little bit of background on her. So she's a 21-year-old Caucasian female, lives in Washington, D.C. She is bisexual and identifies as non-cisgender, so she kind of more female than male, but not entirely female, and works in sales. In terms of her sex addiction, some of her background, she was doing a lot of camming and watching people have sex, lots of phone sex and masturbation, usually up to right before treatment. It was about 3 times a day, using a lot of Tinder and Instagram for hookups. And her casual sex right before treatment was pretty much every night. And it got to the point where there was like choking, punching, pain exchange as part of the sexual acting out. She also had a history of infidelity in all of her relationships. She had a history of alcohol use, and then when she would relapse on that, the sexual behaviors would really increase. And she had a lot of hopelessness, as I mentioned, suicide ideation. When she was 8, her depressive thoughts started, and she never really received good treatment for her depression. And it included, suicidal ideation, as I mentioned, some self-harm behaviors in her background as well. So she has PTSD. I'm going to tell you about her trauma history in a minute, and a history of a bit of disordered eating, which is very common with our females with sex and love addiction. And also history of self-harm and ADHD. She was medicated on Adderall, and when she came in, our psychiatrist did not feel like she had ADHD. And so we think she was probably unnecessarily medicated. And I spoke to her after she left, and she was feeling like she didn't have ADHD, and she was doing really well. So I think that was a misdiagnosis. Anxiety, panic, and OCD. So her history, she was sexually abused by her uncle when she was 8. We have very, very high rates of sexual trauma in this population, so that's just extremely common for us. Mom was physically abusive and an alcoholic. This should say when she was drinking, because she would act out when she was drinking. A lot of high parental conflict. Her father was kind of her protector, and she would get in the middle of her parents' relationships. And then she had a rape when she was 16. Her main drugs of choice were alcohol, marijuana, cocaine, and MDMA. The cocaine and MDMA were infrequent. Here's a couple quotes from her about her. These came right off her psych eval. I have recurring nightmares about being molested or raped by my immediate family. I've had sex with 93 people, some of whom I don't remember. I find it difficult to be sexually satisfied by sex that doesn't involve violence. For the past year, I've secretly struggled with my gender and social identity, and I have seen my birth as a mistake or a cruel joke by the universe. So it kind of gives you a flavor of how she sees the world. I'm going to share with you just a little bit of her testing, and you may not be familiar with all of these tests, but I'll kind of explain what I'm seeing on these. So this is the ZAST, the sexual addiction screening test. The average inpatient is about a 14, and she's an 18 out of 20. So extremely high score there. She met all the diagnostic criteria for sex addiction. I shared with you the 10 criteria we used earlier today. She met all of them. So basically feeling like unsuccessful attempts to stop her behavior, feeling like her behavior is out of control, using it to self-medicate, spending excessive amounts of time on her behavior, having consequences in all areas of social functioning because of her behavior. And this is a binge purge scale, meaning that she would binge on sex and then she would try her hardest to withhold and not have sex and feel a lot of shame and guilt about it, and then would binge on it again. So kind of a pattern of binging and avoiding.
What's the therapist one? You had a client call, a therapist call, and a lead call.
Oh yeah. So on the test, the client endorses what they think that which symptoms they think they have, and the therapist does it, and then you match them up and see if there's agreement. Sort of another check for the therapist to check what their perceptions are. Yeah. So she had lots of consequences, mostly emotional consequences, physical, spiritual, family, friends, financial, and had a lot of preoccupation and feeling out of control. So this is the SDI. It has, as I mentioned, there's actually 47 scales on this test. But I'm just going to give you the ones that she scored in severe risk, which is in these red areas, is fantasy, networking for anonymous sex, cruising behavior, and that's basically picking up people that she has no emotional connection to and having sex with them. Isolated self-stimulating, so that's her pornography use in isolation. Exhibitionism, she had a big, very exhibitionistic quality to her arousal template, and home-produced pornography. All right, we talked about her drug use here. So this gives you an idea of how often she was using the internet for sexual activities. So masturbation was about 8 to 10 times a week for about 30 to 60 minutes each. How many times do you use the internet for sex? 11 to 15. And then how many times do you seek sexual partners each week? About 8 to 10. So she was using a lot of porn throughout the day and having a lot of regular hookups. All right. She was very much in a crisis state when she came in, so she was a highly motivated client looking at readiness to change. And her attachment style was fearful avoidant. Okay. These are some of her trauma scores on how her trauma is impacting her in different areas of her life. So a lot of shame here, a lot of dissociative avoidance, so checking out, escaping, procrastinating, dissociating, and dorsodepression and orbital hyperactivity, which is like hypervigilance and being anxious. And here's some of her scales around her porn addiction and her use of digital media. So she was very high on porn addiction, a little bit high on moral incongruence, meaning that she was acting outside her values and feeling badly about that. Another one is exploring new genres online. One of the things that she was distressed about is one of the things we see with porn addiction a lot is people will start exploring new areas of sexual behavior online, things that they never thought they would be aroused by, or things that they might find distasteful. And as a porn addiction accelerates, they'll find themselves, sometimes people will start looking at porn outside of their orientation, or outside of with fetishes, for example, that they never thought that they would be into. So she had that experience. So one of the things that she was doing was using a lot of incest porn, which is very common online, actually, one of the most common genres of porn. And so she was looking at a lot of that kind of incest porn. And what ended up happening is it started escalating into her offline behaviors, even though she was very uncomfortable with it. So this scale here, escalation. So what she would do is she would hook up with people and reenact some of those scenes, and have them call her little, little girl, and call them daddy and stuff like that, even though it was distasteful for her. So a lot of her, she was viewing online started rolling into her offline sexual experiences. Demoralization, that's like a feeling of hopelessness, like she would say, I never feel like I'm going to be able to have a healthy sex life, I never feel like I'm going to be able to be, normal kind of thing. And then cognitive emotional impacts. She was also very high on feeling like she couldn't concentrate, lack of motivation, feeling very stressed out because of her use. These scales indicate what her arousal template is, mainly when it comes to porn, or her digital media use. Are you all familiar with the term arousal template? Kind of understand what that means? So your arousal template is what you're attracted to or what you're aroused by. And so everybody has an arousal template, and it's, oftentimes your early childhood years are thought to be very formative in terms of the development of your arousal template. So like the ages 6 to 12, for example. So oftentimes experiences that you have as a child, and sometimes they're very healthy experiences. So like the first boy let's say, I'm making this up, the first boy I kissed had blue eyes, and then I've always been attracted to men with blue eyes, for example. Oftentimes when it comes to addiction or sexuality, when it starts to become problematic, you'll find elements of the arousal template that might be unusual and create problems for you that start in your early childhood. So like, for example, we had a client that was, in his neighborhood, he was the only boy in a neighborhood of many little girls. And all the little girls in the neighborhood were abused by the same perpetrator. And what he was doing is having them urinate on him. And so his first sexual experience was a little girl urinating on him. And so that became very core to his arousal template. So oftentimes when you have maybe more unusual types of sexuality, or sometimes deviant types of sexuality, you can peel the layers of the onion back and find out some of those early experiences that influence that arousal template. And what we're seeing a lot with our porn addicts, that they're getting online during those very formative years, and they're starting to explore pornography that is unusual and becomes very core to their arousal template at a later point in time. And so that's very it's just part of the sexuality and our developing sexuality. So her arousal template, she was very so this has got just lots of different types, but one of the things that she would do, she was very exhibitionistic as part of her behavior. And so sexting and chatting, she would get involved and hook up with individuals and post pictures of herself, and even had some circumstances where some pictures of herself got places that she was very embarrassed to have them. And she also would use accelerators a lot, which is basically she would use pornography that had a lot of very intense scenes. So she used, for example, compilations a lot. Is anybody familiar with compilations in pornography? So compilations are basically when they take porn and they take just the most intense scene from the porn and cut that scene and put it all together.
Oh my God.
Yeah, so it's very, very intense. So like, I'm sorry there's a lot of graphic talk when we talk about this stuff. I hope you can hang in there with me. But let's say it's like facial ejaculations or something, and that's somebody's arousal template. It'll be like one right after another, all compiled onto one reel. And so it becomes a very intense form of porn use. So she was very high on that, was using a lot of compilations to intensify her porn use. Also sex apps. Most of even her friendships were developed by use of sex apps. She had was using them all the time, every day, and lots of, hooking up and connecting. Now they have geolocation features, which means you can find how close the nearest sex partner is and within like hundreds of feet. You guys familiar with that? Okay. So she was using a lot of those features. Okay. Now we always, it's in this field when you're working with people specifically with sex problems, we always ask what kind of pornography they're using specifically to get an idea, because it's not, it's really, the treatment differs depending on what is being shared. So, like, for example, if you have somebody who's into wife swapping, it's different than somebody who's into underage versus somebody that's into granny porn. It kind of changes the flavor of what you're working with. So here's her primary genres: amateur, cunnilingus, squirting, lesbian, and teen. So it kind of gives you an idea of her arousal template again. So I had just started, we were using a new assessment instrument, and I had given it to her, and she had, when she was leaving treatment, she volunteered to do that. So this is a phone call between she and I. So it's very casual. But I was checking out with, how she felt like this assessment kind of fit for her. And so it's just her describing some of her behaviors. So I'll go ahead and play that at this point.
And so it just made me, it made me just really unmotivated, because I was just always like needing to go into my room to watch it, like constantly. And like, I'd be hanging out with people, with my friends, and I would be like, I need to go in my room for a little bit. And then I would like go into my room for 5 minutes and come out, everybody knew, and everyone would be like, nice, like all my roommates knew. And it was just like something that everybody just grew like accustomed to around me. Which is like really strange to think about, and even my parents grew accustomed to it, which is like really gross. But they knew, like, because my mom walked in on me once, she was like, she knew that to just leave me alone, and that if I went upstairs for a couple minutes, to just leave me, because I was doing something that they didn't want to know about. And so it just made me, and I would be late to things. I would not go to certain social functions in order to do it. I was frequently late for things because I was doing it, which was just really, and it would really disappoint people, and I wouldn't be present with them, obviously. How can you when you're just like constantly in that mindset? You're not ever here, There were things that I started watching that I was like, where like I would be like, oh my God, I would never watch any kind of porn that was about, even step siblings. That's disgusting. I would never watch that. That's so gross. And then I found myself watching it pretty frequently. And in some of them, they, of course, legally they have to say in the, I'm guessing legally they have to say in the title, oh, like stepmom and stepson, whatever. But it was to the point where some of the videos I was watching in the actual porn, they never actually said step. Like they never said step once. They would call them mommy and daddy, and you're my sister, you're my brother. And I have a brother, I have a sister, my parents are alive, and it like was really, and I would find myself, masturbating to it, and then as soon as I would climax, I would be like, this is disgusting. Like, I can't believe I just watched this. Like, is there something, like, is that what I like? Is that what I want? Like, I don't feel that way, but is there something subconscious that I like, that, and then like, it's like, what's wrong with me, And of course I don't feel that way, but I was like, well, how could I watch this and be aroused by it if there's not something subconscious that makes that, like, something subconscious there? And I was like, it was just it was so shameful, and I never talked to anyone about it because I was so disgusted by it. That definitely escalated a lot. And it was just really watching this kind of porn, this kind of like theme of porn, and then suddenly it was like, I was having sex with people, and I like needed to be called, like I needed to call every man I was having sex with daddy, and I needed him to tell me I was this like good little obedient girl, like little girl, like that was a big thing for me, and it was so disgusting to me, and I knew like came from the porn I was watching. That was one thing that we talked about in the Meadows, where they were like, oh, you know, no more Tinder, no more Bumble, no more any of those apps. And I was like, I don't know how, and I was like, well, obviously then I can't come up with a dating plan because I don't know how else I would meet people except through those apps. Like I of course I've come across people like, you know, in real life, but I've only met people like either through those apps or like at a bar, like, and it was like not any like kind of girlfriend boyfriend material. Like that was kind of that's so it's like, and yeah, and especially as I became more isolated and I became you know, more socially anxious, like as soon as I got to recovery, that was when I started feeling uncomfortable with my body and like finding my breasts and not being able to connect with people even on a friendly level. And like that was definitely when my and so it just made me it made me just really unmotivated because I was just always like needing to go.
I think you guys kind of get the gist of it, right? So any questions, thoughts, comments? We have a little bit smaller group this afternoon, so have a little bit more time for that. Yeah.
I'm absolutely new with this, so it hurts.
Yeah.
It literally hurts, and you know it's I've studied a lot, and it's like, what is under this?
Mm-hmm.
What is under this?
Yeah, that's what we're going to get to. So, you know, when we have that history of trauma, it can come out in so many different ways, and this is just one other way to medicate. And, you know, so often we just think that, you know, we think about binge eating, we think about substance use, but this is another mechanism for that. And so it helps reduce the distress, even though ultimately it creates it, but it's a distress reduction behavior, and over time it gets solidified. And so it's, it's very much driven by trauma. Yeah.
Just for my education, because I'm not familiar with all the genres, is the incest genre, is that taking us in?
Is the incest genre taking us into offending behaviour? You know, what they're watching? Are these children?
So there is a lot of porn that crosses that line. You know, there's rape porn. There's, you know, obviously there's child porn, or what we call sexual abuse images. There's a lot of pornography that crosses that line into offending, and so there's certainly, there's certainly that creates that, it has that quality to it. Mm-hmm.
Just on the line of one of the things about things like incest porn, they will always say that they're legally of age, or very often.
Yeah.
So there's hints of the immorality, the illicitness of the encounter because it's within families, and that carries some potential legal connotations, but it's not, in that sense, illegal material.
Yeah. Because
they always claim to be, you know, barely legal teen or just of age or that kind of scenario. But of course, it has the potential to progress with people to areas that are illegal.
Right. So, you know, in the areas that are illegal or unhealthy, like for example, child pornography, you know, it can strengthen an unhealthy arousal template. So if you have somebody that has, you know, a propensity for minor attraction, and then they keep on viewing child pornography, that's certainly going to kind of help to solidify that arousal template. And all the porn, there are, you know, a lot of the porn that looks like it's teen or minors. There, you know, you hope that they're all actually over 18. I know that there is porn out there where it's not, obviously, but they couch it as barely legal. And so you take 18-year-olds that look very young, that have that appearance of being very young. Mm-hmm. Yeah.
I had two questions. One was the therapist in the beginning, if they hadn't done that sexual inventory, was there anything, had this lady been in therapy a long time, and was there anything a therapist might do in order to avoid what could have happened?
Yeah, I don't think she had been. I think she'd been in therapy in the past, but she had re-engaged in therapy with a new therapist. And so this was a new client for him, and he had just done that assessment and got the information back. So had been re-engaged. She had re-engaged after a period of not being in therapy.
And then the other question was, I worked in the States and we used to have to disclose, anything that you say, because of federal law that is a child at danger, we will need to take further. So what happens if you have people who potentially are using child porn?
Yeah, that's
How do you deal with that?
Yeah. So in the States, we have 2 states that you have to report if they knowingly download child pornography. So a lot of people viewing porn accidentally view child porn. That does happen. But it's when they are knowingly downloading and saving it to, then that's when it's a crime. But just because something is illegal doesn't mean it's reportable. And so there's many states, and that's actually better for our clients, because then if they don't think it's reportable, then they'll come in for help.
Exactly.
And one of the problems that they have in California and Pennsylvania, the 2 states that right now is reportable, is that people won't come in for it. And so then they just don't get help. Yeah, it's really sad. So there's been a lot of people trying to combat those laws in the states, and in those 2 states in particular.
Thank you.
Yeah.
Thank you. You mentioned about a male doing the assessment, and I just wondered what your protocol is in relation...
In terms of gender.
Yes.
In terms of the therapist's gender.
Yes.
Yeah, so, I think that you don't necessarily have to be the same gender. I think that it really depends on the situation and in the circumstance. Our unit is gender specific for women. We do have a couple male therapists that work. They're not the primary therapists, but they do specialty groups that come in and work with our women that work really well with them. So I think it just depends on the specific therapist and who they are and how they interact with the clients. Some of the best sex addiction therapists I know that work with men, even some of the best offender therapists I know, are women. So it just kind of, it kind of depends on, who you are as a therapist and, how you interact and are able to kind of cut down things like sexualization and that type of thing if it happens.
Do you give them the choice?
The
clients?
The
client the choice on the gender therapist?
So in our program, the clients are women, or the primary therapists are all women. I think if they didn't want to go to one of the specialty groups that a man was running, we would honor that if they were in that place. We haven't had that issue. But obviously when it's outpatient, they're calling and they're picking the gender of their therapist off in many cases. Yeah.
Just a comment. I think it can be very reparative.
Yeah, it can be very reparative. Absolutely. Yeah, if you have a good experience with that, that gender, and in my experience in this line of work, it doesn't really matter necessarily your gender or what you look like. At some point you're going to be sexualized by these clients, because that they sexualize, that's their primary preoccupation. They're thinking about that all the time. So like I referred, just as an example, when I was, I gained a lot of weight with my pregnancies, and when I was just 9 months pregnant, I was almost 250 pounds. So I was the size of an NFL linebacker. I was huge, absolutely huge. And just, I thought, well, surely nobody's going to, sexualize me now, right? And sure enough, that week we had a patient come in and his arousal template was big pregnant women, And on that unit at the time we had, a very diverse staff. We had a African-American male, Latino male, older white female, gay male, white female. We had like every kind, and we all got sexualized at some point in time. So it is, it's part of this work, and it's part of, one of the things you have to, deal with as a therapist when you're doing this line of work. Yeah.
So
So I was downstairs, and it seemed to be talking specifically about in the UK, asking a questionnaire about sexual abuse history, and it didn't seem like that was a question that was being asked. And I'm sorry, I didn't stay long, but there's some new volunteer thing that they're doing here to try to get those numbers, that they don't have that information. And so I was thinking, and it was hurting me to listen. And then I come in here and I think, well, we're not even getting the trauma history. We're not asking the question. So, you know what I mean? Like, we can't get at treatment for that because we're not even asking the question. You know?
So what you're saying, let me see if I'm hearing you right. So what you're saying, if you don't assess for the sexual trauma, you might be missing a whole element of treatment. Is that what you're saying? Yeah. I agree. Okay, so let me get back into the slide so we can kind of focus on the complex trauma aspect of it. All right, so when we're talking about complex trauma, we're generally talking about trauma that is prolonged, repetitive, and oftentimes extremely threatening to the client. And usually there is a traumatic stressor that is interpersonal in nature, meaning that it is premeditated, planned, or caused by another human. So there is a betrayal there, usually by someone who was supposed to care for you, right? And usually, obviously, this starts in childhood, continues through childhood, and then over time, we see more traumas accumulating as an adult, which I'll talk about in just a little bit. And so this obviously occurs a lot of times at vulnerable times of life, like childhood, but also it can occur at other times, like times of disempowerment or infirmity and that type of thing. And the issue with complex trauma is that the reaction is often more difficult than it is with trauma that is not interpersonal nature. It's much harder to understand, for example, and to psychologically assess and wrap your head around the meaning of why dad incested me than why the car accident happened. Does that make sense? So there's, because you have that, that interpersonal component, it actually makes it a lot harder to process. So usually you have a combination of what we call big T and little t traumas. Have you guys heard that terminology? Okay. So usually you have the interpersonal component, lots of trauma over the course of the lifespan, and oftentimes you have big ones and little ones, and it's cumulative. Okay. All right, and actually, again, the WHO has done it again because they actually acknowledged in the ICD-11 complex trauma, which is a huge step forward for our trauma, the trauma field, because that also has been a diagnosis that people have been pushing for a while, and they finally put that in there. So here's their description of that. I'm not going to read it because I think this graphic does a little bit of a better job. So you can easily see it. So in order to have complex trauma, according to the WHO, you have to have current PTSD symptoms, re-experiencing of the trauma, avoidance of reminders, and a persistent sense of current threat. So you have the current symptoms of PTSD, and then on top of it, you have CPTSD symptoms, which are affect dysregulation, negative self-concept, and relationship disturbance. And so you have that sort of overlaid on top of the original PTSD symptoms. So I'm going to talk about these three areas with female sex and love addicts as we go along here. So many of you saw in my earlier presentation, I often collect art therapy drawings from my patients. So this one was a female, and her father incested her. And so what he would do is he would come down into her bedroom and stand in the corner or some area of her bedroom, wait for her to wake up, and then get in her bed. And so when she had nightmares, she would always have the nightmares of somebody standing here, or a shadowy figure over here, or a shadowy figure over here. So this is her description, her drawing of her nightmares. And so for her, you can see very clearly, the PTSD symptoms that she has, and she was having a lot of issues with the affect dysregulation, a lot of the relationship problems, the negative self-concept that came on top of that. So sort of a classic PTSD presentation. So I'm going to cover that. So yeah, hold on to that. It's basically difficulty managing your feelings. Yeah. All right. So the first characteristic I'm going to look at those 3 characteristics as it applies to female sex and love addicts. So the first one is relationship disturbance. So one of the things that's really interesting is there's been numerous studies on attachment in female sex and love addicts. And for whatever reason, one of the things that we see in more than one study is that the women tend to have the most insecure attachment styles when we compare to non-clinical population and to males. So as you can see here, here's the controls, here's the male sex addicts, and here's the females. And so you see very high rates of, they're usually preoccupied or fearful avoidant. They mostly fall into these quadrants over here. Very rarely do we have dismissive females. We see that more in our male sex addict population. So you can see here, this is another different study. Cartesian plane is what this graphic is called. So the black are the male norms, the white are the female norms. So you can see by just looking at this how many fall in that secure attachment style. Most people, right? Now when you look at male addicts, you see most of them not falling in the secure attachment, but the women really are even higher rates of insecure attachment. So that is fundamentally, a core issue for our ladies when we're talking about this population.
I just don't quite understand preoccupied.
So preoccupied. So here's a good way to understand this graph. So this is the experiences in close relationships scale by Fraley. If you guys are ever heard of that. So it ranges on 2 dimensions. So over here is anxiety about relationships, and here is avoidance of relationships. So the preoccupied style is anxious and not avoidant. So they're anxious about relationships and they really want them. Down here, they're avoidant and anxious. So they want them, but they're scared of them. So you get this thing, like, come here, go away, right? And so we see that a lot. So these are the predominant styles of attaching that we're seeing with this group.
Can you say a little bit about the other 2? Just a second.
So the secure is, kind of straightforward, and that's the people that you feel like they're, comfortable in their relationships, they're safe in their relationships, have long-term attachment. And the dismissive is like, I don't need you, I don't need relationships. It's not important. That kind of interaction. Yeah. All right. So when I think about the relationship disturbance, when I'm thinking about our female population, the core belief that came to me was others cannot be relied upon. That is a very central belief for our women. And so for many of them, intimacy creates intolerable anxiety, but they want it. They crave that attachment, they want that attachment, but it's scary. And so, like I mentioned a little bit earlier in my talk, so it's easy to use porn. It's they get that sense of sexuality from porn. It's easy to have this casual sex because it doesn't demand intimacy. In the relationships that matter, those are scary and those are harder. And so you see a lot of, come here, go away, repeated breakups, a lot of reactivity in those relationships. That's all very common. Okay. So this is just a quote that I really liked from a research article looking at this. It says, our clients' most frequent presenting problems for complex trauma are not the many symptoms of PTSD, but their failed and failing relationships. They want to love and be loved by someone, and it's not going well. So it's this sense of, oftentimes, if you're thinking about complex trauma and a child that's being abused over time, they have to learn how to have a relationship with caregivers that are unnurturing and unsafe. And so they get accustomed to associating and being okay with forming bonds with people that are not necessarily safe and healthy for them, right? And so they develop this kind of pattern of connection that is not, usually not in their best interest. So what we see, unfortunately, is a lot of repetition of the trauma. And so one of the things that they talk about in complex trauma literature is because of some of the high-risk behaviors that come with the self-medicating of the trauma and the tendency to repeat trauma, that you end up with a significant risk of re-victimization for further traumas. So they're more likely to get an abusive relationship, for example, in which they're being abused. They're more likely to maybe be in a situation that's high risk, where maybe they experience another rape in a situation where they're drugged or something like that because of substance abuse. So there's lots of circumstances in which we find that our complex trauma victims end up re-victimizing themselves or getting in situations in which there's a perpetuation of more trauma. And that's what we see with a lot of our females in this situation. So lots of high-risk behaviors, lots of self-destructive behaviors, high rates of substance abuse, high rates of exploitive and abusive relationships. So this is a quote from Bessel van der Kolk talking about the compulsion to repeat trauma, reenactment, re-victimization, and masochism. He's done some interesting writing on this topic. And he says, anger directed at the self or others is always a central problem in the lives of people who have been violated, and this itself is a repetitive reenactment of real events from the past. Compulsive repetition of the trauma is usually an unconscious process that, although it may provide a temporary sense of mastery or even pleasure, ultimately it perpetuates chronic feelings of helplessness and a subjective sense of being bad and out of control. Gaining control over one's current life rather than repeating trauma in action, mood, or somatic states is the goal of healing. So basically, Bessel's theory is that even though it may be painful, that there's sort of a drive to have mastery over a situation that at one point was out of control. And so that's one of the reasons why we see the patterns repeat themselves, right? And so that makes a lot of sense when you look at it from that perspective. And this is along with Pat's theory. By the way, Patrick Carnes is my father, not my husband. I always like to put that out there. In his book, Betrayal Bond, he talks about traumatic bonding. So this is an idea in which people get involved in relationships that are exploitive and abusive, yet they're like a drug for that person. Have you ever seen somebody that is they're addicted to a really unhealthy person, and they know it's a bad relationship, they know that it's, how it's going to end up, but they sign up for it anyway every single time, and they can't seem to pull themselves out of it? So that's traumatic bonding. He often talks about it as, you guys remember the Peanuts cartoon with Lucy and Charlie Brown? How Lucy would come out and she would put the football out, and every time Charlie Brown would come out there and kick that football, even though he knew every time she was going to take it away, right? So that's what we see. Same, we know that the relationship's dysfunctional, we know it's not going to be healthy, and yet that pattern keeps on going. So this was an example of a drawing. This was one of our ladies, and she had her father was very physically and emotionally abusive, and she had 4 serious relationships, all of them physically and emotionally abusive. So, and you got this, she's depicting the trauma bonding here. So when Bessel talks about this, he talks about how, when you ask why do people stay in these relationships that are so abusive and damaging, and he says people seek attachment in the face of danger, that's normal to want to attach to somebody when you're experiencing fear. And so we see that with intrafamilial abuse, for example, in domestic violence situations, where victims will respond with increased dependence and paralysis in their decision making, not wanting to leave their abusers. And we have very high rates of domestic violence also among our population. So that's not an uncommon thing either. So this is just a quote from the book Prince of Ties. Maybe some of you might remember the movie. It says, like a lot of other girls, she chose a husband like her father. I think I understand it. They start connecting love with pain. They begin searching out men who will hurt them, thinking they're searching for love. I thought that was pretty a compelling quote around trauma bonding. Okay, so the second characteristic of CPTSD that we were talking about, you remember we talked about relationship disturbance. Second one was negative self-concept. So unfortunately, our ladies come in with tremendous toxic shame. Just a lot of self-loathing, a lot of self-hatred, blaming themselves for everything. So we use the terminology negative self-attribution, where every trauma is their fault. If I hadn't have been, walking alone down that alley, I wouldn't have been raped. If I hadn't have done, XYZ, this wouldn't have happened to me. So always blaming themselves for the trauma, always internalizing that worthlessness and those feelings of toxic shame. So obviously that leads to a lot of self-destructive thoughts and behaviors, and an impaired relationship with the self. A lot of times they don't really love themselves very much. They know it's not good for them, but they won't come to their own assistance and believe in themselves. So the core belief here is I'm not good enough. And so we have to work really hard to start combating that notion of I'm valuable, I'm worthwhile, I can do this, I can take care of myself, helping them define what healthy sexuality looks like and what would be positive relationships for them. I think there's a few repeats on the drawings for those of you guys that were here earlier. This was one of our females here. The black here represents shame. And I think I shared this one earlier, so forgive the repeat. But this is the inside, her inside, where it's saying that this is her father. You're so stupid. You're so worthless. And she's crying. She feels fear, self-loathing, disgust, self-hate. And on the outside, what she does, she's got her finger up, the joint in the other hand, and all the men around her. You're beautiful. You're amazing. So sexy. Damn, girl. There's our fire alarm. Okay. So this also, goes along the lines with, I think there's culturally a lot of issues to think about when it comes to women and sex that also impact treatment and self-concept and self-esteem for female sex and love addicts. Kelly McDaniel wrote a great book called Ready to Heal, and she talks about some of these cultural beliefs for women around sex. So there's, often this women have to be the good girls, the sort of, you have to be pure and all these expectations. Yet there's also, I'm not really a woman unless someone desires me sexually or romantically. I must be sexual to be lovable. So there's a lot of conflicting cultural messages that we get about sex that can be really confusing for women. So on the one hand, there's positive reinforcement for being sexual, and then women can be shamed, like slut shamed, for example, if they're acting sexually. So there's a lot of mixed messages around sexuality for women. Our last section is before we get into treatment, is affect dysregulation. So this is when, difficulty coping with emotions. So the core belief here is I can't deal with my life, I can't handle my feelings. And so what we see is a lot of self-medicating, a lot of numbing, oftentimes risk-taking behavior. Sometimes the affect dysregulation comes out as control, like restricting, avoidance, perfectionism, those control behaviors, which can be used also to reduce anxiety. Distracting, avoiding intimacy, compartmentalizing. So for those of you that weren't here in my earlier talk, compartmentalizing is basically having secret parts of the self. And so a lot of our female sex and love addicts will have different parts and different personas, and that don't know, for example, let's say, these are my using friends that I go out with, these are my work friends, and these two groups don't know about each other, and I'm a completely different person when I'm here with this group of people. And so there's a lot of secrecy around behaviors and no one person that really knows them completely. And so getting them to be open and honest and really share themselves completely with their support group is a huge part of treatment, being able to just really be themselves. Incidentally, just group therapy is cutting edge treatment for sex addiction, whether it's for males or females. Having that experience of the group, having that support of other people that identify and relate to what you've been through and what's been going on for you is really very, very important. Very important aspect of treatment. And then also resentment, it can also be a big thing. I often look at, resentment can be addiction fuel, and it's very, very common with complex trauma, which I'll talk about in just a minute. So I think I shared this drawing earlier. This is one of our females. The husband is done walking out the door. Mom needs help. As one man to the next man brings the client vodka, pills, and food. And this was a female who was going on Craigslist and also abusing a lot with heroin and medicating with pharmaceuticals. And you can see here too, this was, there's a lot of self-harm. You can see that here, a lot of cutting behavior, alcohol, different drugs, and you can kind of see the different parts of the self as we were talking about earlier. This is an interesting case. So sometimes when you have multiple addictions, you will see that they can come in different patterns over time, if you evaluate things over time. So this particular client was married 4 times, and her pattern was basically get married, gain 100 pounds, become sexually aversive, get divorced, lose 100 pounds, become sexually promiscuous. Get married, gain 100 pounds, become aversive, get divorced, lose 100 pounds. So she was flip-flopping food and sex with restricting and binging. And so you can see this is compulsive dieting with sex addiction, and this is compulsive overeating with sexual avoidance. So it's very helpful to look at those patterns of binging and restricting and when, what is happening over time. Okay, we talked about this a little bit. This was one of our clients that these aren't her names. She did give me permission to use this drawing, but they are her real names. The black is herself. Her real name is Erin, and Erin is pathetic, a freak, forgettable, useless, insecure, ugly, disposable, weak, unwanted, a loser, laughable, insignificant, and stupid. Whereas Anna is her name in the industry. So she was in the porn industry and in the prostitution business. And Anna is strong, confident, unstoppable, beautiful, lovable, talented, striking, and adored. So you can see with that how intense that compartmentalization is there, that she completely identifies with the different, persona with her when she's acting as part of in industry. So again, part of the healing with that is to integrate, let go of all the secrets, live a congruent public and private life, be honest with people about what's really going on with you, be accountable to your group so that people really know you. And when they do that, their symptoms get much better. Their anxiety gets better, their depression gets better. That's a really big component to healing for our ladies and for the men. Bill W. often said, "You're only as sick as your secrets." You guys have probably heard that quote before, right? So it can be very healing for them to let that go. This is another drawing. It might be a little too faint for you guys to see, but here she's got her head cut off, and these are all the different parts of herself. Can you guys see that? It's too faint. Okay. So here, the I here is her self, her actual self. The world is, she had this part of herself that would travel the world and was very wild and free-spirited and adventurous and very much a party kind of party girl persona. This here is her eating disorder, the Pac-Man. The heart is her love addiction. This is alcohol, perfectionism, and this is her little wounded child part, and this is her porn addiction. You can kind of see all the different components.
Can I just ask if when these people come to you, you look at their addictions and you decide, you give them the tests, some of the inventories, and you decide where they fall in terms of, does their drug addiction come before their sex addiction, or?
So yeah, sometimes we do have a little thing that kind of helps. It's a self-test that they use in terms of identifying what's your primary addiction. I have a little exercise that I do with the ladies where they kind of rate themselves on the criteria on each of their, kind of put their addictions across the top, and they total it up. And so they kind of identify which is their primary. Sometimes they have two. Sometimes, you have multiples, but one is definitely more than the other. So it kind of gives them a sense of where they line up. But what we teach is that when you are in recovery, you have to look at all the areas in which you might be compulsive and medicate. And you want to live in balance in all the areas so that you don't slide from one addiction into another. Because it's so easy for people to go to treatment and then leave and gain 60 pounds in the first 6 months, right? Or something like that. So we want to make sure that they're not going into another addiction. Any other questions?
Could I just ask, you've been talking about sort of the extreme end of the behaviour, and I was just looking there at the attachment style, the dismissive avoidant and the fearful avoidant, and they never get into treatment. So in the sense that the possibility that they've shut down completely, and
so
what can be done for them?
Yeah, we get a lot of fearful avoidance in treatment. Yeah, we do. We get a lot of them. They're distressed, that they're unhappy that they can't maintain a relationship. So, and in the male population, we get dismissives. They're often coerced by their partner to attend. That wouldn't be an uncommon thing, but we do get that from time to time. But it is less common to get a dismissive in treatment, for sure. Yeah.
And do you work in America?
Yes.
I'm just wondering who comes to you? Like, is it people who have a lot of money? Who are the people?
So it is obviously it's a treatment center, so they have to have some money to come in, and it is a higher end treatment center, but we do take some insurance. We do have a military contract, so we get a lot of military people. So we end up with a lot of, unfortunately, on our unit, we end up with a lot of rape victims from that. So we usually, at any point in time, we only have a 10-bed unit, and at any point in time, we usually have a couple from the military that are rape victims. So it's...
Yes, and would people stay with you for a while, or they go away to their lives and come back? And I'm just
Yeah, we
curious.
get them for 45 days. Yeah, we have them for 45 days, yeah. Yeah.
And is there a point in time where you feel it's appropriate to work with people, especially drug and alcohol addiction, to look at their trauma?
Oh, absolutely. We do. I mean, trauma is core to our treatment process. So on our unit, they get internal family systems, EMDR, somatic experiencing, post-induction model, Pia Melody's work. They get art therapy, and they get psychodrama. You know, all of those. So trauma, and they're doing individual therapy sessions of EMDR and SC while they're there. So trauma is like, that's really what they come there for, is for trauma treatment.
So, what are the outcomes like for children of these patients? You know, they must be young reproductive females, probably in their 20s, between 20s to 40s, or probably in the 50s, 60s. But you know, one just wonders, you know, these women actually have young children, between anywhere between 5 to 10, or probably 2 to 10. What are the outcomes? I mean, probably some of the partners will actually stay with them just because they have children and actually bring them to treatment for that reason. So maybe they might actually help in keeping the family unit together, or probably the only thing that keeps the family unit together prevents the partner from leaving. So what are the outcomes?
So one of the things that when I my focus is, I'm a family therapist, so like a lot of my clinical work is family therapy. So one of the things that this is obviously an area that is just devastating for the families, right? We talk about betrayal trauma for our partners. We also use the terminology sex addiction induced trauma, which is, I think, true for both partners and for the kids. This is traumatic for children, absolutely. And you know, a lot of them learn information that they just have no business knowing. You know, it's very difficult. You know, for a child, you can't unhear this kind of thing. And so what we see with our partners is there's oftentimes a process of discovery that happens, because obviously this is a secret life, right? This is always, you know, done. Often sex addiction is kept hidden from the partners, and so over time there's a discovery where they start finding out information, and it's, you know, sometimes it's the kids that make the discovery, and they're holding the secret, and they don't know what to do, and so it's devastating. It's devastating for the children. They absolutely need just as much support and care. One of the studies for partners showed that 70% of the time partners have symptoms of PTSD post-discovery, post-discovery after they find out the information about the addiction, and about 72% have severe functional impairment. So you have both parents, one is in their addiction and the other one is melting down, oftentimes. And so you have the kids left in that situation. It's very, very painful and traumatizing. Yeah.
I was just wondering your thoughts on treating a sex addict in an interpersonal group with other addictions, not just sex specific.
Sure.
Does that make sense?
Yeah, I mean, I think it can help if it's all that they have, but it's not ideal. You know, there's something that's really liberating about being with other people that have the same problem, and having that, the shame reduction that comes from that. Honestly, like the group process is a huge part of the magic of treatment. Like the connections that they make amongst each other is something that we as therapists could never give them.
Yeah, I was just wondering how, if that could actually compound some of the shame that's nobody in that group.
Yeah, I mean, I think it depends on what the group is wrestling with and the makeup of the group, and if other people have sexual issues in the group or whatnot. Yeah, so I would. It's definitely not ideal. Yeah. You guys have a lot of good questions. Okay, awesome. All right, so moving right along. Okay, one thing just to touch on in terms of affect dysregulation, and I bring this up just because it's with complex trauma, it's so incredibly common. So when you have a long history of traumas, lots of repeated traumatic events, you get sort of a history of injustices that have been done to you. And it's very, what ends up happening is over time that accrues and it accumulates and resentment accumulates. And you see this a lot with substance use as well, where you end up having sort of a grievance story of all the stuff that has happened to me, which eventually can turn into entitlement. And well, then I deserve this because, or, you know, kind of can make people go into a one-up and be explanation to why I'm unworthy and the shame, and also you know, an explanation for their ongoing behavior, a rationale for their ongoing behavior. So, you know, it's just like, you know, the Grinch, who was, you guys remember the story of the Grinch, that was, had so many, he was shamed for his differences, abandoned, hurt by those he trusted and loved. He withdrew and became obsessed with those whose thoughtlessness hurt him deeply. So you can get that kind of adherence to that story. And so letting go of resentment, this is, you know, a common issue with our women and for the men as well. So helping them work through resentments can be a big part of the treatment as well. I call resentment addiction fuel, as I think I mentioned earlier. Okay, and so one of the things, obviously, when we have a lot of difficulty with affect regulation, we want to help them manage that. So we do a lot of activities to try and help them help manage affect. Are you all familiar with Dan Siegel's window of tolerance? I'm sure it's very common. So basically it's a band of arousal within which you can function well. And when people get outside of that, they get stressed and are less able to function. And so we do a lot of strategies for self-care and regulation. So things like support, using their group, mindfulness, yoga, our ladies do Tai Chi as well, exercise, shame reduction behaviors. We use some DBT for that, and art and music. So just trying to teach them those tools to help manage feelings of toxic shame, help manage them when they get stressed, and so that they can take some of that home with them. Okay. So any other questions before we keep on going? Yeah.
This psychometry for sex addicts, does it rule out bipolar disorder, mania, for example, disinhibition of bipolar disorder?
You really have to look at mood disorders if you have bipolar on board, because obviously bipolar can include sexual acting out in a manic phase, right? And so, if the sexual acting out only occurs when they're manic, then we don't want to treat that as an addiction. Yeah, so
it responds very well to medicine.
Pardon?
It responds very well to medicine.
Absolutely.
How would you correct similar disinhibition and some sort of disinhibition? Is there any how can I word this? How come medicine control for inhibition and psychotherapy help in the same direction also for such patients?
How can medicine control?
Is there any correlation between these two situations? If this one responds to medicine, this one responds to psychotherapy?
I don't know if I know the answer to that. I don't know if I know the answer to that question.
The thing with what I understood that you're saying is the importance of this whole treatment is to look at the trauma underneath that has caused the behavior in the first place,
Yeah.
isn't it?
That is absolutely so.
You're healing the trauma. It's not about finding a plaster for the addiction.
Yep.
It's about healing the trauma that caused the addiction.
Absolutely. Yep. Absolutely.
Does it make sense?
Mm-hmm. Thank you. Okay, so we have about 9 minutes left. I'm keeping you to the very end, right? Okay, so I'll try and hit some of the high points here. So when you have complex trauma, the therapeutic relationship is so important. We focus a lot on, that connection and bonding. And so there's a lot in the literature about how important the therapeutic relationship is. So I'm going to kind of skip over a couple slides that just emphasize that point. This is Alan Shore. I'm sure some of you are familiar with his work on attachment and how important the therapeutic alliance is. So in terms of treatment, this is some of Christine Courtois' work. I don't know if you all are familiar with Christine. She's done a lot of research in the field of complex trauma. And she talks about treatment as occurring in 3 different stages. And the first stage is, just creating a very safe container and connection with your client. And so focusing on things like, and this is, you're building that therapeutic alliance all the time. We want to have them see us as their advocate and their protector, and being very connected and attached to us during this phase. So healthy boundaries, safety planning, assertiveness training, self-nurturing, self-soothing, emotional modulation, strategies to contain trauma symptoms, attention to wellness, stress management, support for medical and somatic concerns. Unfortunately, our complex trauma patients have a lot of physical health problems. You might be familiar with the ACEs study, in which they showed that the more adverse childhood experiences you have has a direct correlation with your long-term health outcomes. Things like your mortality, your longevity, cancer rates, all sorts of stuff like that. So the more that we can teach them wellness and self-care is very, very important. So this is sort of the early phase. We want to get them in, make them feel super safe, comfortable. We're their advocate. That's a really important part. The second stage is where we're reprocessing some of the trauma. So this is where we're revisiting, reworking the trauma, careful processing to integrate the traumatic material along with its associated and often avoided emotion. And so if you think about so many trauma treatments that we have out there, that's what they're doing. And we want them to be able to express pain and grief with witness and support, while all the while we're maintaining stability and safety. So that's sort of the middle of the work. So if you think about, for example, the PIT model, the PIA's model of post-induction therapy, they are reworking that with witness and safety. If you think about internal family systems, same thing. EMDR, same thing. So we're doing the meat of that work during that middle phase, and allowing, witnessing them processing and connecting those feelings with those traumatic experiences. And then the late stage is identity and self-esteem development, improving relational skills and relationships, intimacy issues and sexuality, and understanding the meaning of the trauma and the losses.
Can I just ask, can witnessing though sometimes re-traumatize? Can the witness re-traumatizing?
So yeah, you want to, obviously you have to, you don't want to do, I think that there are times when things like exposure and, exposure therapies and stuff can be re-traumatizing. So you want to make sure that what you're doing is within safe parameters and is not re-traumatizing the client. Yeah.
How do you do the second and the third one? It's witnessing
them down very easily, but how
Yes.
do you do that?
So this is oftentimes very long-term treatment. So when we talk about complex trauma treatment, it's usually like a long-term treatment trajectory. One of the things that Christine talks about, she says, there are some people that will never get past the early stage, that have so much trauma that they just have to stay in phase 1. And then you have some people that will go through and kind of get to an advanced stage of treatment where they'll be able to focus on those longer term issues. But this is definitely long-term therapy. Yeah. Okay, well, I am mindful that, we have, so obviously there's so many different models of trauma work that you can use within that framework, right? So I'm mindful that we only have a couple minutes left, and I'll take one last question if we have it. Yeah, go ahead.
Thank you. I was just wondering, in terms of the patients that you see, what percentage would come from families where there are parents with alcohol or drug problems, and what percentage of those would have CPTSD?
Mm-hmm. It's very common. I would say very frequent. I don't have a number or percentage, and I'd be afraid to throw one out without some research to back that up.
Mm-hmm.
But it's definitely a very prevalent issue, for sure.
Okay.
Yeah. Thank you. Well, one more quick one, yeah.
It's kind of a question and a statement at the same time. I think what I've noticed, what sparks a really good conversation, is, and we were just talking about it a little bit earlier on, is there are some professionals that will say working on the trauma too soon, and that to do that as a primary wouldn't be appropriate. So for PMLD, a lot of different forms that are out there. Then there are other people that say, well, you need to work on being the container and dealing with the most present, to say substance misuse, for example, and deal with that later. I'm just wondering, where is that line? How do we get to that place to understand yes or no? What is the answer?
Yeah,
what's the answer?
It's a balance, and I think it's you start slow, and always monitor how they're responding to treatment. If you start to see them destabilize, you have to back up a little bit. We have a little bit of an advantage when they're inpatient because they have so much containment around them, and so we can go a little faster and a little deeper. In outpatient, obviously, you have to go slower and tread a little bit more lightly. But it's it's definitely an issue that has to be monitored all the time. Yeah, thank you for that. Okay, well, you guys have been great. Thank you for all the great questions. Appreciate it. Have a good weekend.